Back enough. Sufficient about that? Yeah. I think if more than 90% is back. I think that was. So the next topic that we're going to go through is PE, or pulmonary embolism. This very much wants to be, this is going to be a relatively brief presentation, really, because we've covered everything on it between the oxygen delivery on week 1 to shock, by one of them, and this morning we literally covered everything that we need to talk about about PE. So, okay, I'll just go through it anyway. That's fine. So, but it's good. Just to have a wee chat. But it'll be interesting, as Colin was saying earlier on. We're going to have a chat about the treatment and the recognition of it. There's actually a couple of slides in here that I would love to discuss with you guys from amongst clinicians to have opinions out there. So what we would want to describe and discuss pulmonary embolism, what it is, describe the basic pathophysiology of an acute PE, define massive PE, and describe the basic treatment for pulmonary embolism. So what is it? So a pulmonary embolism occurs when thrombi from the venous system, they dislodge and go into your pulmonary circulation. Happy so far? Excellent. This results in pulmonary vascular occlusion, which impairs gas exchange at the alveoli. Yeah? Cool. You remember the little green embolus that Colin put in today while he was explaining? That is essentially it. You've got an embolus of some sort that travels across from your veins into your pulmonary circulation and stops the blood supply. And then obviously that will impair the gas exchange. What are degrees of severity in a PE? Why are PEs different?
Might depend on the size of the clot.
Absolutely. So tell me about the size of the clots. So what is that going to affect?
Well, it depends. If it's a small clot and it's just blocked a smaller vein or something, then the area that it affects might be small. But if it's a massive one further up the system, then it's going to block a larger area. A larger area. I couldn't have said it any better. That is exactly it. So the difference absolutely. So the difference in my PE is the fact that it's not like the one condition as such. First of all, the embolus that travels from your venous system could be different things. So immediately we jump to it's a blood clot. Yes, could be a blood clot. Anything else it could be? Huh? Absolutely, yeah. Fatty tissues that can travel from one of your veins up. Anything else? Sorry?
Amniotic fluid, is that, for pregnancy, after pregnancy, postpartum?
Yes, so that is quite toxic, quite right. Although it might not necessarily form an embolus per se. But yeah, but that's dangerous when that happens. Yeah? Air. Yeah, air. You can get an air embolus as well. That might stop circulation. As you said, a piece of fatty tissue, a piece of scarring tissue as well. Be a scar caused by initial damage, such. Also, there could be all sort of things. So when we talk about an embolism, an embolus is something that will cause an occlusion. And it can be indeed a blood clot, but can also be can be fat, can be air, can be all sorts. Okay? The size of it varies, and depending on the size, that will depend on how much of your lungs that will affect. As you quite very rightfully say, so if it's just a tiny one, will just affect a smaller area of my lungs, but if I've got a large PE, that will affect a much larger area of my lungs, hence potentially just getting more obvious symptoms and make it a lot more deadly in that case. So pulmonary embolus, so the reason I say all that is because a pulmonary embolus has a significant associated mortality, but let's be logic about this, yeah? Not all pulmonary embolisms have a high mortality of it? Obviously, it will depend. Like bigger ones, they do have quite a large associated mortality, but you can have much smaller, much more innocuous ones. And essentially, this is a representation of one here. Here we go. You've got, this is a DVT, just drawing from veins here, and then will end up in your pulmonary circulation up here in your lungs. Risk factors of PE. Most significant PEs originate as venous thrombosis, as we showed in the picture there. That's why would that cause the bigger ones in the lower extremities?
Because your calf muscle works as your venous pump. Yes, but something else a little bit more simple about that. No, you're right. You're absolutely not wrong on what you're saying. Absolutely, you're quite right. Why would a bigger one generate in those blood vessels? Larger veins.
Huh?
Larger veins.
Bang on. That's just larger veins. You know, I mean, that's why the most dangerous ones, that's where they develop, because you do have a larger diameter of blood vessels in your legs, in your calf muscles as such. So that's when they start developing. Before you actually start recognizing any symptoms of a DVT, it needs to be a relatively large clot, for example. Yeah, and as soon as, before you start seeing actually paresthesia, or you start actually seeing discoloration of your extremities, if it's in your hands or fingers, it's not very big and you start getting some symptoms. But before you actually start getting symptoms of a DVT, unfortunately, sometimes they need to be quite huge. For the in your placements, if you're lucky enough, you might see some of them getting removed. And I genuinely thought it was just like a little ball of clot that comes out. And I thought, and that's what always was in my head because of all the pictures of it in books. I show, look, there's a little DVT. I swear I've seen like something like this size just pulled out of someone's vein. It was mental. So hopefully you'll get to see that in your placements. It will give you quite an idea on how big they can be, and you can understand how much, even if a piece of that gets dislodged and start traveling into your pulmonary circulation, can cause huge damage. Major risk factors of those of thrombus formation: age above 60, because everything starts going downhill. At that point, everything starts downhill since 30, as far as I'm concerned. You know what I mean? Then that's it. Recent immobilization, why? Why is a good question to ask your patient? Back to what you were saying, absolutely, it's your calf muscles that act very much as a pump to your lower extremities venous system, yes? If you don't move your leg, or if you just stay on the sofa for like however many weeks because, I don't know, because you had surgery, because you've been unwell and so on, all the stasis of the blood, that is an increased risk of clotting at that point. Recent CVAs or MIs, recent surgery as well, malignancy of any sort of a growth, malignant growths as such, prior thromboembolism, which means that you're clearly prone to it, use of estrogen, of hormone replacement therapy. They do tend to mess up with your clotting properties as well. So there is a risk of associated to that. One other one we can bring in there is your use of the pill as well, and that it does increase an increase of risk of PE. I like the fact that when the COVID vaccine came out, and the statistics of if you get your AstraZeneca COVID vaccine, these are the statistics of the risk of you getting a PE. If you're on the pill, the risk is about 10 times higher. But no one says anything about that. You know, I mean, I go, what? Really? But so the pill is okay, though. But this vaccine, careful getting vaccinated. You know what I mean? So as I found that a bit, but anyway. Let's not get into the politics of that. Smoking, obviously, because of the constant irritation, as we talked about, of your airway. And then pregnancy, because really the density of your blood becomes a little bit greater. So you're always at slightly higher risk of PE if pregnant. So if you get pregnant, try to encourage movement. But
That was not happening with my wife. Then you carry it. Fair. Fair. But fair enough, I can't. So if I want to sit here, I'll sit here. Fair. Fair. And Amy shall never see it. Okay, I'm just saying this right now. Okay, so fair enough. So that's your risk factors of PE. Now, finally, that's the bit that I really want to say. How do we, let's go a little bit offer. Let's go, how do we diagnose a PE? How do you know if someone's got a PE?
Breathless.
Huh? Person might be a bit breathless, absolutely, or very breathless, absolutely. Anything else?
I've always heard you can see it on an ECG, but it's not always accurate.
What was that?
I've always heard you can see it on an ECG.
Oh, I'm so glad you brought that up. Good stuff, good stuff. So you can see it on an ECG if someone's got a PE or not. Have you heard that before? Yes, absolutely. And you've got some Rasmani. Yeah, absolutely. If you I can't even remember the numbers anymore.
S1, Q3, T3.
Yeah, S1, Q3, T3, I think so. Yeah, that's it. And, you know the amount of time that I try to spend, just I need to remember this and be an absolute smart arse at anything. So whatever I do, do a 12-lead ECG on a patient and see if I can spot it until my bubble got burst. And the actual affinity for that is so low. So yes, some patients have that. It's not a diagnostic tool worth having or spending a lot of time trying to remember it, unfortunately. So yes, there is some ECG findings about your PE, on a PE patient, but the affinity of it is so low that it's just not worthwhile being a diagnostic tool for ourselves. So in a way, that's one less thing that we removed from the ECG day, which is good. I'm not saying don't look into it, but it's more like something like, so I would diagnose my patient with potentially a PE. I would still do, of course, because some of them present with chest pain and all the rest, and so obviously you would do an ECG anyway. And it's the kind of thing that you look at and you go, oh, look, they do have that presentation, but I wouldn't use it as a diagnostic tool per se. I've got a slide and I'll tell you exactly. Good. So ECG, not great. Anything else? Someone with a PE? Huh? Okay, I'm glad you say that. So tell me about the auscultation then. What's it going to sound like? Huh? Oh, good. Okay.
The auscultations, because the air intake has been reduced by pain, not by a mechanical process, right? Because the embolus isn't actually reducing the lungs' capacity, it's just causing the pain when you take the air in.
That is correct. Absolutely. My embolus, it's in my circulation system. So unless you get to the point where I actually end up with a necrotic lung by that point, which then stopped moving because it's just dead, the actual lung capacity remains the same. You know, you won't have necessarily at all a reduced air entry. You might have, you're quite right, the person might be in pain and maybe sore when they breathe in, so they have like reduced air entry in the sort of a shallow breathing more than anything else. But that blockage, this embolus, it's not in your bronchioles, it's not in your airway, it's in the vasculature system of your lung. I'm not saying don't auscultate. Of course, if they've got a breathless patient, yes, you're going to auscultate your patient. But a more common finding is this patient is breathless. They can't breathe very well. SATs are horrible, and yet there is a good bilateral rise and fall of the chest and a good air entry all the way to the basis. And you go, what? You know, that is more, you know what I mean? That is most likely for you to happen other than there is a reduced air entry on one side. Yeah? Because the embolus itself is in the vasculature of the lung, not in the actual airway per se. Does that make sense? Good, excellent. Cool, so that's one thing. It can happen that you've got a reduced air entry on one side after a while, or huge ones, absolutely, after a little while, yes. It's more common though for pre-hospital clinicians to find someone distressed, in pain, can't really breathe properly, you know, and yet though they've got good air entry. So there is no adventitious sounds on auscultation as such is more common. Good. Anything else for a PE? Sorry? Tachycardia, yeah, absolutely. The person will be tachycardic. First of all, if anything, let's start with pain and panic and a struggle to breathe. Absolutely. So you will be quite tachycardic. Quite right. Anything else?
Any heat or swelling in limbs?
What was that?
Any heat or swelling in limbs?
So that can happen. Tell me about that. Why would that happen?
It's just
Sorry, I don't want to put you on the spot, but okay, so potentially we talk about heat and swelling in limbs. Admittedly, that would be more of a later sign, yeah? Fair bit. Later. Why would that, there's a risk of that happening though? Huh?
Because of the thrombus, the blood can't pump through the lungs, so it starts to back up through the heart.
Yeah, absolutely. So once I've got, see, that's the tricky thing, the little ball of embolus. It's far bigger than that, it can be bigger than that. So absolutely, so if I do actually have a blockage, that there might be a backlog of blood. It admittedly has to be pretty big for that to and actually start getting peripheral edema. Such it is pretty big, and it's quite after a while. So smaller ones will not have that level of presentation, but absolutely, I like the thought behind it. Yes, there could be some heat, there could be some swelling, some peripheral edema because of the backlog of blood, of circulation that is not able to pump through as such. Good. Anything else? Huh? Well done, absolutely, yeah. So low sats, usually it's a thing. Quite a large amount of patients that will have a lower saturation, tachypneic, tachycardic, breathless, in pain. Usually that's quite your main presentation. Will you ever know for sure that they have a PE? No, we won't, isn't it? It's the kind of thing that will make, I think this might be a PE. And then see what they do at hospital kind of thing, yeah? And but it's good to start having an idea of what it might look like. Now, interestingly, I don't know, how many of you have heard of the Wells criteria for PE? So the Wells criteria is actually quite good. So let's say you have a patient that you go, I'm not 100% sure what it is wrong with you. It's a little bit breathless, but otherwise, physiologically, most OBS are okay. I don't have a huge amount of uncanny doubts. But you know what? You're not the only ones. Not everybody that presents with a little bit of breathlessness are going to go through A&E and they're going to do all sorts of tests and scans. Not to everyone. So what they do, they go through the Wells criteria, and it's like a scoring system. And this scoring system, to us, it doesn't mean a huge amount, but for a hospital, but if you do calculate it, your Wells score, it will tell you if this particular patient in hospital will get advanced screening for PE or not. That's what it is, So essentially, you calculate that. You're not going to make a diagnosis out of it. It's not a diagnostic tool, but it tells you, well, I'm going to take you to A&E, but with this kind of Wells score, they are not going to take any more of this. But, and then up to you really to make your decision on what you're going to do with your patient. So that's what it looks like. It's your Wells score. There is, clinical signs and symptoms of DVT, and you score 3 points. There's no alternative diagnosis. That's another 3 points there. Heart rate above 100, which has got quite a high affinity to PE or tachycardia. Immobilization for over 3 days or surgery in the previous 4 weeks. Previous DVT or PE. Hemoptysis, so if you start spitting up blood. Malignancy with active treatment in the past 6 months or under palliative care.
I took a patient in who had received treatment for breast cancer, had received all clear. We took her in with breathlessness, tachycardia, stats, etc. She passed away. And they said that, why is it not more likely? Is it the treatment for the cancer? Or?
Yes, that's how that's how I understood it, indeed. That will sort of impact certain bits on your clotting capabilities. Colin, you have anything more?
Yeah, it's exactly that. Your risk of, or your sort of risk of activating the clotting cascade is higher. chemotherapy and then having a tumour altogether can alter factors in your clotting cascade as well. It's just increased risk of clot.
That's it. And that is your Wells criteria. You get a score out of it, and then depending really on how much you score, still the explanations that is whether they're gonna get what type of tests they're gonna get in hospital or not. I've got it on an app on my phone. It's obviously in the critical setting where the patient is really unwell. Of course, I'm not gonna stop and get a Wells score of it. But someone that is breathless, hypoxic, and in chest pain in front of you, don't stop and do this because that's just a waste of time. Okay. So here, there's just, as we were talking about, the size of the emboli. So it's a larger emboli can wedge to the main pulmonary artery, causing a large area of lung circulation can be occluded. That's the worst ones. And a smaller emboli can occlude the peripheral arteries, causing intraalveolar hemorrhage as well. Here we go. That's your PE. So this essentially is what Colin told you earlier on, and just taking it straight from my slide. Unbelievable, you keep doing that. So creating your ventilation perfusion mismatch because of your increased dead space, your dead space ventilation due to it. And as pulmonary artery systolic pressure increases, afterload in the right ventricle increases, leading to a right ventricular failure, and potentially that's when we can start getting, on a longer term, some edema and some swelling and such. Okay. We talked about your clinical presentations. Quick recognition of PE is vital because of high mortality. Some patients might be asymptomatic altogether until the very last minute. Certainly, I had patients that were okay, and then they were not okay. And we got into hospital, and I go, whoa, that was sudden, and then they were dead. And you go, oh, okay. You know what I mean? So it can be incredibly rapid as such. And often patients, as we said, will be distressed, hypoxemic, tachycardia, and chest pain. ECG use, we discussed, here we go, S1, Q3, T3 syndrome. Okay. After you've done ECG thing, and after you passed your ECG exam, have a look through it. It's a cute thing to show off. It's in the arm, you say, oh, look, this person's got S1, Q3, and I think he's got a P. Ha ha, here you go. And a lot of people are going to go, oh, wow. That's it. I would go, oh, wow, if you remember. So well done. But per se, I wouldn't use it as a diagnostic tool. Colin, would you?
Anything you set the back of the ambulance after the job.
Yeah. Oh. Yeah, you guys say, no way, look. It's like, perfect. It's like your Wolf Parkinson White when you see, when he said, sure, no way, look. You know what I mean? Exactly. So you'd see afterwards. Treatment of management of PE. My God, this is just really teaching you how to suck eggs, guys. What do we do for PE? Huh? Diesel, yeah, that's it, not IV. So the fact that we teach you how to put a cannula in, it doesn't mean you can shove all sorts of things in it. Okay? So diesel and oxygen and pre-alert, absolutely. Pain relief is required, absolutely. And that's really it. That's all we can do really for your PE, okay? And so that is probably the most important bit. Prepare for decompensation. I certainly got caught out by that in the sense of, it's really bad. And we knew the urgency of it. And as I said, you're okay, not okay, dead. And you go, oh man, wake up. You know what I mean? And it's just, I was quite impressed. I wasn't as cheery at the time, obviously, but definitely taught me a lesson, on how rapidly it can actually act. Take home points: pulmonary embolism can range from asymptomatic to a completely life-threatening catastrophe. Massive PE is a shocked PE patient with a systolic blood pressure below 90. Particular attention to hemodynamic stability, so get all your obs in quickly and try to start gauge where you're at for your patient, where you're at cardiovascularly. And the patients may or may not have reduced SATs, just like with your lung auscultations. They might have
perfectly, good bilateral air entry all the way to the basis with no adventitious sounds at all. Or if it's been a while, they might have some slightly reduced air entry. And literally, that's it for PE, because what else you want to talk about PE? It's a clot.